And thank you for joining today's Research Over Coffee webinar. It's our final episode of the season. We have a barn burner here with Ruth. I'd like to start first by acknowledging that we are in Mi'kma'ki, the unceded ancestral territory of the Mi'kmaq people. We are all treaty people. And I'd also like to acknowledge the histories, contributions, and legacies of the African Nova Scotian people and communities who've been here for over 400 years. I'm Stefan Leslie. I'm the CEO of Research Nova Scotia, and I'm joined by Dr. Alice Aiken, who's the Vice President, Research and Innovation at Dalhousie University. I have the pleasure today of introducing today's speaker, Dr. Ruth Lavergne. Ruth is an associate professor at Dalhousie University and a Tier 2 chair, Canada Research Chair in primary care. She's an expert in changing physician practice patterns and primary care access. And Ruth's work focuses on factors driving changes and exploring how different approaches can help ensure equitable access to quality primary care in Canada. Physician access is on everyone's mind these days, and the provincial government is focused on transforming healthcare. I'd like to welcome Ruth to share what she's learned and what she can contribute to healthcare solutions. After Ruth's presentation, we'll be taking questions through the Q&A feature. That's at the bottom of your screen, and you can ask questions at any time. And after Ruth's presentation, Alice will come back on and moderate the Q&A session. So I'll turn it over to Ruth, please.
Thanks so much. I'm delighted to be here. I'm going to speak to a question that I get asked by friends and family. Basically, why is it so hard to find a family doctor or a regular place of primary care in Canada? And I'll try to provide some context about how primary care is changing in Canada and some messages specific to Nova Scotia. So I'm supported by the Canada Research Chairs Program and CIHR, but I have no conflicts to declare. So I'm going to just start with my main messages, what I'd love for you to take home from this talk. I'll then step back and provide some of the data and some of the research evidence that support the things that I'm suggesting. And then I'll go back to those main messages and maybe some implications to think about going forward. But basically, to answer the question, if you've only got 2 minutes, if there are more family doctors than ever before, why can't I find one? It really is the confluence of multiple factors. The work family doctors do is changing. And importantly, this is true for all physicians. It's not just those early in practice. It's not a generational shift. It's across the board. Population needs for primary care are changing. We all know the population is aging, but at older ages, people are receiving more care that needs to be coordinated. So there are compounding factors. It's not just aging overall. And finally, the health system surrounding primary care is changing. And so a lot of the administrative work and the central coordination function of primary care is more time consuming. So when those three things come together, we really are seeing a growing capacity gap, resulting in challenges finding a regular place of care or getting timely care when folks need it. I'm then going to give you 3 hot takes, and I'll back these up again. So we need to expand primary care capacity, and there's lots of moves in that direction. But we need to do so thoughtfully, because not all policies that look like they expand capacity actually do. They don't all actually make it easier for people to get the care that they need and access an ongoing place that coordinates services for them. I'd also love for us to reshift our thinking. Primary care policy can't just be about preventing emergency department visits, which is something we hear so often. The value of primary care comes from continuity and coordination, not just getting people in the door and getting them out. It's not access and flow. It's rationalizing a complicated health system. And finally, what I really sort of want to conclude with focusing on is we need to make primary care, and especially primary care in the community, a better job. There's lots we can do around recruitment. There's always a lot of focus on payment. But when it comes down to it, I think we have opportunities to make Nova Scotia a great place to work and strengthen primary care through that. So some context. Again, we have more family doctors per person than we ever have before. And this comes as a surprise to lots of people. That's true nationally. So the green bar here is Nova Scotia and some other provinces for comparison. We've also on average had more family physicians per person than the Canadian average in Nova Scotia, and that's persisted over time. So that seems in tension with persistent concern about family physician shortages. And again, this isn't just Nova Scotia, this is national. This is a photo from BC, actually. One of the things I want to emphasize is that access to primary care is falling, it's not doing so in a similar way for everyone. We see inequities growing wider. Here we're looking at just who has a regular medical provider, a family doctor, or a nurse practitioner, or a regular place of care. Disparities have existed for some time, but they're not growing narrower. They're either persisting or growing wider by household income, by whether you own your home or not, by whether you're racialized as non-white in Canada. Next, I really want to pause a bit here to talk about what primary care does. This isn't my work. This is accepted sort of within health services work. It comes from Barbara Starfield. And it emphasizes that primary care is supposed to be that front door for the health system, offering first contact access. It also needs to be reasonably comprehensive. People need to know that their needs can be met, or they'll be directed elsewhere to get more complex needs met. And really critically, it needs to follow people over time, maintain a patient record, understand the context for people's new conditions, and coordinate services received elsewhere. And it's these two functions, continuity and coordination, that I really want to emphasize as driving value within health systems. So looking across the types of places where people might get primary care, you might be in a collaborative team, a publicly operated clinic that's doing all these things. It's first contact access, but it's also coordination. There are privately operated clinics where people are receiving fee-for-service or other payment from the government, and they're operating the clinic themselves. Again, that may be providing all of these functions. When we switch that to a walk-in style clinic, it really is that first contact access, and we lose the coordination. We all know that people access primary care in the emergency department, and that makes sense because it provides access, and it's also very comprehensive in that you can be directed to necessary imaging, and you know that the resources of a hospital are right there. But again, we lose those functions of coordination and continuity. And then finally, as people are accessing virtually, either through virtual care that's publicly funded for people who don't have a family doctor, or if you're accessing like text-based care that's privately paid on Maple by Nova Scotia physicians, you're just getting that first contact access, and the infrastructure for coordination isn't there. So what I want to emphasize is that in a high-performing system, primary care ensures that the right patient is receiving the right care from the right person at the right time. It's not just a substitute for emergency department visits. There's even evidence that that the congestion within emergency departments really is not driven by relatively simple presentations that could have been dealt with in primary care. We know it's the sort of more complex patients who might require hospitalization and ongoing care following hospitalizations that we really have to be attentive to in understanding workload within emergency departments. So what explains current access challenges? I'm going to do a little bit of a deep dive on one narrative I hear a lot. So our different choices among early career physicians relative to previous cohorts driving capacity gaps. So generational explanations for changing physician practice are really common. We hear them all the time. We hear the stories about committed family physicians who've provided care for communities for decades, struggling to find someone to take over. And we hear about early career physicians. Often it's gendered, often it's women who are understood to be providing sort of valuing work-life balance, or maybe choosing alternatives to community-based practice. Just to be a little cheeky, this lines up with sort of generational differences explained in society. You don't have to go far on TikTok or Instagram to see reels about how Gen Z versus millennials versus Gen X differ with respect to their attitudes. So it maps onto those broader conceptions. So we wanted to do really careful analysis to understand the relative effects of people's age, like how long they've been in practice, period, the calendar year changes over time, and cohort, when you started practice, this generational idea on primary care delivery. Won't go into the details of the methods, but I'll just take you through the findings for this and then speak to other more broad topics. So it is absolutely true that the number of visits per family physician is falling. It is falling in Nova Scotia. It is falling in all of the comparator provinces where we have data. What I want to emphasize, though, is that doesn't necessarily mean fewer hours worked, given changes in chronic disease management, population needs, and health system complexity. So we see that in these plots from the analysis they did, that the average number of visits is falling over time. And you can see Nova Scotia looks similar to comparator provinces here. We also, in this analysis, look at the trends over the course of a family physician's career. So you can see that as people start out, service volume gradually increases and then it drops off. Manitoba, we didn't have as much data, but it's following the same pattern. Nova Scotia, same pattern. In fact, it dropped off a little less among physicians approaching retirement in Nova Scotia than in any other provinces. This is important because it means that just the headcount of family physicians doesn't tell us the whole picture of how active they are likely to be. If you have a workforce that has more people earlier or later in their careers, for sure you're going to see differences in service volumes, and that's something we're experiencing in Nova Scotia now. If it were the case that more recent cohorts are practicing less, we would see a pattern that looks something like this on my next slide. So we would see it dropping down among the cohorts that are entering practice more recently below zero. In fact, what we see is this. So, and you can see like on the left hand, among physicians who entered practice quite some time ago, there's a fair bit of fluctuation. Those are low numbers, so don't read too much into that. But on the right side of the plots, if anything in Nova Scotia, Ontario, and British Columbia, it's actually kind of ticking up. So what this is telling us that there is that there is no additional generational effect among physicians entering practice more recently. That in fact, the changes we are seeing are across all years in practice and all genders. If anything, declines are slightly greater among male physicians. It's also happening across all provinces, even with different payment models. It's just not unique to physicians early in practice. There's lots changing, again, administrative workload, complexity of care, but what this points to is a need to focus on those system-wide factors and sort of get rid of this narrative that if only people were working a little harder and following in the footsteps of previous generations, the situation would be different. The data does not support that. Something else we might be interested in with respect to practice patterns is comprehensiveness. So this has been a topic of like that we've been concerned about for some time. In fact, this image is from the 90s, looking back about worrying that comprehensiveness was falling since the 60s. But here again, we don't know if comprehensiveness is changing more rapidly among early career physicians relative to physicians in established practice. So we looked at the data again across 4 provinces, and we did see that the average number of settings per family physician has fallen over time. So people are less likely to be working in hospital and emergency departments in long-term care as part of their day-to-day practice. But it has fallen across all career stages. The darker bars are those most recently entering practice, and in fact, the differences are smaller for them. Same goes for service areas, like whether you're providing mental health services, whether you're providing pre and postnatal care, things that you could do in an office. Again, the changes are smaller here and they are not driven by early career physicians. I wanted to show you all of those data so that you would believe me that over time we really do see changes, people practicing in fewer settings. We see really consistent findings across provinces given varied models of primary care delivery and physician payment. But as with service volume, there's just no evidence this has changed faster among physicians just starting out. One thing I want to flag, just like while folks in the room are paying attention to primary care, is that while these findings don't point to gaps in training that are specific to more recent cohorts, Reforms to family medicine are underway that do have implications for capacity that we need to be planning for. The College of Family Physicians of Canada has announced plans to increase the length of family medicine training from 2 to 3 years, starting in 2027, though there might be some flexibility there. And this would have workforce implications, including a year with no graduating family physicians. And we also have to pay attention to training capacity. So the people who train residents are already pushing to expand the number of seats in residencies, and this would add to their workload as well. Same thing for people who are involved in helping internationally educated physicians get equipped to start in practice here. And it might make family medicine less attractive compared to other specialties that have sort of a 4-year residency by comparison. So again, this is something that we need to be attentive to that's coming down the road that could further complicate the situation. So again, all this isn't to say that the age of the physician workforce is unimportant. So here again in green, you can see that the physician age has been increasing, and then it actually falls off a little bit in recent years, pointing to new early career physicians entering the workforce. What this means is we now have both more physicians just starting out and more physicians approaching retirement in Nova Scotia and in other provinces. And again, that is part of what we're experiencing in terms of access challenges as people approach retirement and as people are just getting started, that's contributing to the pinch we feel. So again, our changes in primary care are observed across all career stages, which points to broadly targeted system-wide strategies as are being attempted in Nova Scotia now. Since practice differs over the course of careers, it is important to pay attention to the age distribution of the physician workforce, but there's just no evidence that there's a specific cohort effect. It's still important to understand what physicians entering practice want. We did interviews across 3 provinces, and it's consistent. People want to deliver care in team-based models, which is consistent with how they trained and consistent with announcements of more collaborative teams in Nova Scotia. They're looking for alternative payment models with fair compensation. And again, this is a topic of active negotiation now. One of the things we hear a lot about is the ability to take time off with coverage for patients, which really means you have to be in a team setting, and the ability to focus on medicine rather than running a business for some. Others are interested in the sort of more entrepreneurial practice. When it comes down to it, though, people choose family medicine because they want to do fulfilling work that responds to community needs. We just need to make sure that that the nature of that work really does meet their expectations. So if it is not, in fact, changing demographics among the physician population, what is actually going on? So I've pointed to some of this. What other factors are driving primary care capacity? Obviously, the population is aging. We know that in Nova Scotia. We know that on average, the population is slightly older here. But what I want to emphasize is that at older ages, people are being treated for more chronic conditions now than they were 20 years ago. Some of that might be poorer health status. It might be that we're just more actively managing chronic conditions. So this is data from British Columbia. We don't have similar in Nova Scotia yet, but the volume of services requiring coordination has increased dramatically, especially at older ages. On the right side of the spot, you can see that in those purple bars, even so people over the age of 80 are getting more prescriptions, they're getting more imaging, everyone's getting more lab tests, and all of this is activity over and above visits that we need to sort of factor in understanding workload. And then while we have more family physicians per person, almost the entire increase is taken up by people doing work other than community-based primary care. What I want to emphasize, though, is this is people working in emergency departments and working as hospitalists primarily, which are roles we really need right now, and address sort of needed roles within the system. So it's not just a matter of pushing people into community-based practice. But taken together, this means that the volume of services or workload per visit for community-based practice is increasing. So again, we're seeing fewer visits. It doesn't necessarily mean people are working less. So just to pull things together, what's changing primary, or what's driving changes in primary care capacity, or if there are more family doctors, why can't we find one? The work family doctors do is changing. Primary population needs are changing, and the systems in which people work are changing. So again, the work is changing across all jurisdictions. Complexity of care is increasing. And much of this is accounted for, and much of the increase in family doctors is people doing hospitalist or emergency department work. Population aging doesn't tell us the whole story. People are being treated for more conditions and getting more services. And so that role of coordination is becoming so much more important as the population ages. And the systems in which doctors work are changing. So people are spending fewer days in hospital, receiving more day surgeries, which is great for the health system. We don't want people to be in hospital unnecessarily, but that shifts work to the community. And the time it takes to do this work is changing, as navigating referrals is time consuming, and electronic health records don't necessarily save time for family physicians and nurse practitioners. Sometimes they're doing coordination work that might previously have been done by other team members. So what does this mean? Again, my sort of 3 hot takes I want to leave you with. So we need to expand capacity, but we need to do so thoughtfully. So we need to consider training capacity. We can't expect that everyone who completes family medicine residency is going to be working in the community. So we need to plan accordingly. And I want us to pay attention to that 3rd year of residency. And then moving to team-based practice is something we've been saying for years. But again, we need to do it in a way that actually expands primary care access. So some of the changes we might imagine give people frontline access, but if it's not actually continuity and coordination, so if it's an urgent care clinic where they can see you quickly, but it's not offering ongoing care, and then the work of coordination gets kicked back to community-based primary care that need to update records and follow up on that visit, we've just generated sort of more coordination and work in the back end and more administrative work in the back end for that one visit. So just being really attentive to access, yes, but also continuity and coordination. And what does it mean for administrative workload in the background? And does that actually make the system more efficient? So I can answer questions about that with specific examples if it's helpful. Again, I want us to rethink our focus around primary care as preventing emergency department visits, recognizing the value is efficiency of the system as a whole, and that emergency department congestion really isn't driven by simple conditions. And this means supporting continuity and coordination in the community. So adding urgent care access points for people who already have a regular source of care can increase coordination work, and drawing primary care providers out of longitudinal care, community-based clinics to provide care for simple things, evenings and weekends isn't good value. And then finally, we need to make community-based primary care a better job. So efforts to support patient coordination and reduce administrative workload will free up time and expand capacity, but also improve recruitment and retention. This makes it, that's one of the things that people complain about as part of the role. So that means being attentive to what paperwork expectations for primary care might be unnecessary. And then when we're thinking about technical solutions, we need to consider workflow within primary care, not just connectivity and exchange of information. So what is actually involved in updating and entering information on the primary care side? And then finally, addressing working conditions can attract people early in their career or retain them later in practice, which is important given that age distribution. And this includes the ability to take time off with coverage, team-based care with skilled administrative support, and the opportunity to do fulfilling work. And I think it's this piece, making community-based primary care a better job, that is our real key for recruitment and retention, not one-time bonuses and not getting into an arms race with other jurisdictions. That we really do have an opportunity, especially with recent announcements, to make Nova Scotia one of the best places to work in primary care. And that would also, by extension, make it one of the best places for patients to get care. So I'm excited about the possibilities. I'm happy to speak to any questions. Thank you.
Thank you very much, Ruth. I appreciate that. I'm Alice Aiken. I'm the Vice President for Research and Innovation at Dalhousie University, and I'm going to host the Q&A portion of this talk. I'm going to dive right in. And we have people have asked if you will share the deck. So we'll, yeah, no problem. We'll go back and do that. So that's great. So I think you addressed this, but somebody just wanted some clarification. Has the average number of patients that a family doctor takes on dropped? And would that seem consistent with your conclusions?
Yes, that's absolutely true. So measured in a few different ways, the average number, the panel size, so the number of patients someone would feel responsible for, the average number of unique patients a doctor sees in a year, and the number of patients doctors see per day have all decreased. And again, they've all decreased. We had 4 provinces to look at across the board. So that total change in volume is also translating into the number of patients who have a regular place of care or who get in to see a family doctor.
Yeah. And so if coordination of care is something that was previously done by others, why has that changed and why are doctors burdened with that extra admin? So is it, and we don't really have a provincial EMR yet, right? So like would one patient, one record make a difference to this?
So absolutely, like a single patient record is really key to high performing health systems. But I think what I want us to pay close attention to is like the nitty gritty of how it's implemented and what it feels like on a day-to-day workflow perspective in primary care. That has to be the focus. That the same policy change, centralized referrals, or a single EMR, if it doesn't work for primary care, then you could still just actually increase the time spent to get details attended to and in coordination. So again, this is sort of related to the question about like who's actually doing the work of making sure we're following up on referrals, on renewing prescriptions, and how many clicks is involved? What does that look like? How many times do you have to go back and re-refer because someone's not accepting patients or doesn't see patients with that profile? It's all of these processes that might seem small, but when replicated across a work day, a work week, and a health system, can really shape what's being asked of primary care. And it's also no one's favorite part of their job. So again, it connects up to recruitment and retention. Is something we hear all the time about what's contributing to burnout and frustration. So yes, to one patient, one record, absolutely. But the work to get it right at point of care and within the workflows of clinics in Nova Scotia is what's going to really get you that efficiency and capacity in primary care in its implementation.
Yeah, and on that, we know some jurisdictions have gone to patients manage their records. Would that be an effective model? You walk in, you've got your app with all your patient info, any doctor can look up anything they want.
So I think there are great reasons for patients to have access and ownership and control over their own information, independent of coordination and continuity. And especially for people to know where things sit within the health system. It's discomforting to know, the referrals in process somewhere. Well, is it with my family doctor's office? Is it with the specialist? Where am I sitting? To be able to have that information and monitor it in real time would offer reassurance and comfort to patients. But the reason they don't have it is because it's not actually readily available. So I think we have to fix these structural pieces within the system for that reassuring information to be available for patients. So I don't think it's as simple as making patients responsible for continuity and coordination. That makes things better for people who have the skills and resources to do that, but it doesn't actually help some of the people who might be struggling the most to pull everything together. Right. So yes, but it doesn't alone solve the problem.
And, yesterday we heard an announcement by Nova Scotia to expand primary care clinics, and some of those are multidisciplinary clinics. So what about the concept of all health professionals working to their maximum scope?
100%. This is an all hands on deck situation. So that's entirely consistent with increasing capacity. Where I'd suggest a little bit of nuance, and this can be challenging, is there are ways to build teams that provide better care for patients that don't actually expand primary care. What I mean here is adding, for example, people need access to physiotherapy and occupational therapy, and many people struggle to access that if they don't have private insurance. Same thing for mental health support, for psychology. So we can add depth to teams that give people better care, but they don't actually get more people through the door, and don't actually get more people seen for day-to-day primary care. So we need to do both. But I think there has been frustration in the past of building out teams that, again, add depth, but don't actually expand access. So it's a little bit of a balancing act. And it's also just not a matter of saying, okay, we have 10 people, you're a team, now go win. That we really need to, we don't do that for sports. We don't just say, like, get on the field, make it up as you go along. That attention to those implementation processes, so people know who's doing what team members you can rely on, and what you can, what type of work that they can take on. Those implementation processes are key to realizing the efficiencies that teams can bring. I think it has been a frustration for policymakers that us academics have been saying team-based care, and they're like, okay, teams, we got them. It's not working. And so it's those pieces around implementation and making sure it's constructed in a way that actually expands access, capacity, and lets us attach more patients to primary care, that I think are key considerations as we expand collaborative teams, as we roll this out more widely in the province.
Yeah, and you know, I would also suggest that in a family team, if somebody is getting all of the care they need, they're far less likely to show up at an emergency department. So overall, for this system, it's probably better, right?
Absolutely. But we want them to not show up in the emergency department because they're healthier overall, not just because, like, you know, there was an urgent care clinic where their sprain could be dealt with after hours. Like, we really want to build this through better population health and better outcomes. And that's what we can see with a sort of rich multidisciplinary team.
Yeah. And just to continue on that, somebody has noted that they were struck by a colleague they had who practiced family medicine in Spain. And in Spain, all physicians are federal civil servants. They're salaried with benefits. They have administrative and infrastructure support. They have productivity and health targets, opportunities for lateral or vertical moves, you know, like civil servants. We certainly know that where they've tested that salaried model in Ontario, I was at Queen's for a long time, and where they tested, that was a one of the areas, I forget what they call the program, but it was the physicians were all salaried, that productivity did not, in fact, went up. And so is there any thought of implementing something like that in Nova Scotia?
This could get spicy fast, but this idea of what physician autonomy means is really central to how we've structured care in Canada. This dates back to our central sort of agreement around publicly funded care, that we would pay for things publicly, but it was left up to physicians to continue to plan their own practices and simply bill the province instead of patients. So that is built into how we have structured our health system and has been an ongoing tension. I think for some physicians, it is important that they run their own practice. They can make all those decisions. And so the traditional fee-for-service model might work great for them, which is fantastic. It doesn't have to be the same for everyone. But absolutely what we do hear from physicians when we did interviews is an appetite for someone else to take care of overhead, someone else to be doing that administrative work so they can focus on medicine. And actually that makes them feel like their sort of medical autonomy is more fulfilled and that they're doing the work they trained for in a supported environment. So I think we are moving in that direction. It just doesn't have to be the same for everyone. And those points about career development as well, that, you know, you start up a practice, you're just doing that for the rest of your life. There's no sort of, there are more limited opportunities for leadership roles. Of course, those exist, but a structure that allows for mentorship and new challenges and career progression is also consistent with this idea of making primary care a better job, and that looks quite different in other systems compared to our own. So I think those international comparators are very relevant, and I think that's the direction we're moving in. But again, it all comes down to like the function of that team. Is it the frustrating environment where you're an employee and have no control? That's a very different situation. from a supportive working environment where you're able to focus on what you do best.
So I'm going to just move a little bit more to the mechanics. So do you have any thoughts on whether the medical campus of Dalhousie at CBU will expand access to primary care, and what are the challenges? And along with that, do we have enough residency positions in Nova Scotia for all of the graduating family doctors who want to be in family practice? And is that going to change with the increase of 1 year?
So I can't fully answer that question. I don't think anyone can quite yet. So this is going to be sort of a non-committal answer. We have been adding more family physicians to the system for years, and we still have this challenge. So that is not the only thing on its own. More seats in medical schools and even more residency positions aren't going to solve this. We really, really do need this organizational reform that makes better use of the physician resources that we have in the system, and that keeps people in community-based work that we really need and makes that well supported. So just more people into the same broken system will just be in the same place we are now. That said, again, with this recognition that hospitalist work is now how most hospitals operate, we need people with generalist training to do that work, that emergency departments are staffed by people with family medicine residencies, and also that people with family medicine training are flexible to sort of adapt and changing contexts. It's family physicians who jump in to acquire additional training in the context of a toxic drug supply and meet the needs of people who use drugs. In the past, it was family physicians who managed the HIV crisis and who got those skills to meet new and emerging needs. That flexibility of a family physician workforce, the other health system roles, and what I've outlined in terms of aging, complexity, and system mean that I do think overall we will need more family medicine residency seats and a greater proportion of physicians going into family medicine. What I cannot answer, again, is exactly the mechanics around that third year. What I can say is that just like family physicians in the community are strapped for time, people in training roles are strapped for time. They're doing their best to expand the seats in residencies. And so adding another year will have implications that need to be thought through and resourced accordingly. So that's an area of uncertainty for me as well.
I'm going to ask another question here, but I'm going to editorialize a little bit because this is sort of my area of research. So, family doctors have typically been the gatekeepers of medical flow. And is it time to let go of that as a pinch point? And I started my career, I'm a physiotherapist by background, and I started my healthcare career in the military. And in the military, the government of Canada holds the liability, right? It's in our system, it's the physicians. So in the provincial systems. And so I could refer to an orthopedic surgeon. Yes. I could refer to rheumatology. I could do all of that. And it to date, that health system, the military health system, even when corrected for age and gender, and they provide everything. They provide all counseling, all pharmacare, but even when corrected for age and gender, is still the most cost-effective system in Canada. So how do we shift that? Like, how do we remove that pinch point?
So this is such a great point. And what you've illustrated there around physio is key. So if deployed in the current structure where a family physician has to see you first and then say, oh, you might benefit from physio, go over here. We're not adding capacity. If we have structures where people who have musculoskeletal concerns would really benefit from the specific expertise of a physio, probably as a first assessment, then we are growing capacity. We're just deploying them differently.
Well, so physiotherapists are a direct access profession right across Canada.
But so not as funded within our system, and
except in the public system. So bizarre.
Exactly. Yeah. So that absolutely makes sense. I think there are other examples of, your family doctor might not be the most approachable person for sexual and reproductive health care or for mental health needs. That it is better for us to have multiple access points and not simply one option. But as you've observed, for that to actually work, there are pieces behind the scene. One patient, one record, a comprehensive medical record that flows across settings would be the backbone to it. And attention to medical legal responsibilities and clarification, as you've observed, is different in the military system, would be part of it. That those are sort of those are sticking points for that transition right now. And so I would say we have to move a little bit cautiously to make sure we've addressed those pieces before fracturing continuity and coordination in an already confusing system. So there's a little bit of a tension in terms of what comes first to get to that goal, where there are multiple entry points that can get you where you need to go.
Yeah, and so I have a question here from somebody who would know this better, certainly better than I. Wasn't aware of this, but have family physicians been part of the conversations about what collaborative teams should look like?
So this is an ongoing, I think, attention, and it's not unique to Nova Scotia either, right? That there is this feeling that family physicians haven't been at the table, that they haven't been included in decision making, and that's common. And I know that's also sometimes a frustration for government and for physicians associations. We're like, we're doing our best, and like there are people at the table. So I would have to speculate a little bit here, but I think where some of it comes down to is that on the ground, like clinical rollout, the mechanics of how is it going to operate, how health authority managers are working with the medical staff, that sort of on the ground consultation is a really big part of it. But I want to also be clear that the whole team has to be part of that. It's not just a matter of engaging family physicians. And I do think that there is not specific to Nova Scotia, but there can be a tension between who's actually represented in those senior physician leadership roles versus, it's not typically people just entering practice, for example. So it's who's at the table and the leadership roles, but also, again, what are those processes around implementation, consultation, and working as a team to get processes right that I think have excluded clinical team members in different ways. But yeah, I'm sure there are people on the call who have much more insight into those processes and more detailed knowledge of the Nova Scotia setting than I am. So I'm just speculating there.
Yeah, no, that's, and look, we're happy you're doing the research you're doing. We have, this isn't time to address this question. We have about a minute left, but could you just expand a bit about the equity issue you mentioned during your presentation?
Yeah. So what we see when we look at data across Canada in individual provinces is that over time that there's always we know healthcare is patterned by social position in different ways. So if a system's working well, it's probably the case that people who live in lower income neighborhoods get more care as poverty makes people sick. We've actually seen that reverse in Canada, where it's now the case that if you live in a wealthier neighborhood, you're slightly more likely to have family physician visits and have a regular place of care. And that translates then into who's being referred, who's getting access onward in the system. I think it happens in subtle ways. When you have to work hard, use all your social connections to get access to a family doctor, that privileges people who have time and resources to do that. And when we have deployed new primary care systems in the past, sometimes those go to the communities that are ready to run with it and not necessarily those in greatest needs, not in Nova Scotia specifically, but broadly. So through these mechanisms, we have seen growing inequities in access. And that's an issue of really ongoing concern for me. So thank you for letting me add to that.
Yeah, no, thanks so much. And listen, Ruth, Dr. Lavergne, thanks so much for your time this morning and an extraordinarily engaging discussion that I think is not just relevant to Nova Scotians, it's relevant to everybody. Thank you, everybody.
Sure. Thank you so much.